My name is Seth, and I am doing the CAM or pincer deformities for the project. It's also known as FAI, femoral acetabular impingement. So for the model, I used uh, the dry clay, and this is my representation of the pelvis. So for the femur and the head of the femur goes in just like that. It's rounded off. There's the neck, and then the rest. I didn't do the rest of the foot down all the way down to the foot or the shin, because the disease I chose mostly affects the hip socket and the head of the femur. So this would be a normal hip joint. And then for this one, this is the affected area. The one that's colored red is a CAM deformity. And then also on this side, that one, that is colored black for the pincer. So to show the progression of disease, some people have the pincer, which is the black one, or the CAM. Some people have both, and it prevents rotational movement of the femur inside the joint, going either which way, as a normal hip joint would act like. Now, for what is a pincer or what is a CAM deformity, they are abnormal growths. So for the CAM deformity, it is an abnormal growth on the femoral head or the neck, and it's usually caused by excessive activity, trauma to the hip joint itself or the pelvis. It could be hereditary, genetic. It is most identified usually by tight stiffness, immobility to move certain ways, either extending the hip out laterally or rotating it up. There would be limited range of movement with it. The most area that people have this issue is adolescence to young adult age. So from when they start physical activities from about 5 up to 25 is a rough range that I found out that this happens at. For the pincer though, so this is an abnormal growth of bone actually on the pelvis itself, and that is the acetabulum portion of the pelvis, and it's either due to a focal growth of the rim or globally deep socket is what the Mayo Clinic would state it as. And this one would prevent it from bringing the leg out laterally. The CAM usually prevents the rotation of the leg forward or back. Now, how does the morphology or this thing happen? Usually high impact sports. For the CAM deformity, it is still unknown on how it goes, but it is excess. Both of these are excess growth of bone, and with the proximal femoral physis is still open during adolescence, this could potentially cause excess growth if it was hereditary. And then how pincer deformities develop. The morphology represents acetabular overcoverage, which is that little peak right here. instead of combined, where it's smoother, to allow the hip joint to move freely in all directions. And the genetic factors affecting this is the same as the CAM. Both CAM and pincer morphologies increase contact stress between the femoral head and the neck region and the acetabular rim, which also causes meniscus pain or ligament pain in that area as well. For diagnosing, it's usually found on x-rays. For the CAM, they'll usually see it when it's rotated into a frog leg position on the x-ray, and they will see it extend out. So for the frog leg, the patient would be laying supine, and they would bend their leg up and over, which will bring the imaging around the head, the back side of the head, to where they're able to see it directly, just like that. And for the identifying signs for the pincer, is just a regular AP pelvis x-ray, where they can see it just sticking out just like that. They don't have to have any special modalities or special positions for the patient to be in. Now, for other extended issues, there could be MRIs, CTs. The CT would do a 3D reconstruction of the area to see how severe it is. Once these deformities are found, physical therapy is a strong suit on trying to rebuild the area. Most of the time when people have these, they have a lot of weakness, instability in the joints. Usually physical therapy just builds the muscles, ligaments, tendons around it, strengthens the bone to prolong the area if it is a young adult or a child. For older patients presenting with this issue, total hip replacement is usually the best option. Now, for the reason why I chose this, this is very specific on a hip condition. I chose it because I actually have bilateral CAM deformities, personally. So I have it one on this side and one on this side. I found out when I was 23. I did physical therapy. I did strengthening exercises, mobility exercises. It doesn't seem to help as for now, but the range in mobility I have is still there. I still have a good decent amount yet. Maybe when I get older I'll have to have a total hip replacement. But this does fall under the classification of femoral acetabular impingement because it does impinge the ligaments, tendons, muscles, and cartilage in the hip joint, and it does cause that as well. This affects roughly, from the Mayo Clinic, roughly about 10 to 15% of adolescents and about 10 to 5% of adults. So here is the pelvis. This is the acetabular crest right there, and it is bunching off. And this is the femoral head. The CAM deformity is on the femoral neck, so it does change the structure of how round the femoral head is inside that socket. And then that's one right there. and then I will try to compare it to see the differences. So, there we go. And you can tell it has limiting factors.